Hi. So I'd like to talk to you about ketamine, foam's favorite medicine. Ketamine's an old medicine that predates most of our births, but it's experienced a meteoric rise in popularity, largely due to free open access medical education. My only disclosure is that I love ketamine, and I use it routinely for any of its innumerable indications in the emergency department, particularly for patients experiencing pain. Hypotensive trauma patients or patients with pain refractory to opioids, or even opiate-addicted patients who want to avoid opiates. A small dose of ketamine can allay suffering and provide some analgesia. For patients undergoing painful procedures or kids who require sedation, a middling dose of ketamine produces what I can only assume is a euphoric state filled with rainbows and ponies. My ED pharmacists know that there's only really one medication that I reach for when I'm about to intubate a patient in terms of sedative, and that's ketamine. A larger dose of ketamine still protects airway reflexes and provides some lasting analgo sedation so that the patient isn't experiencing pain until the fentanyl and propofol infusions are ready. For agitated delirium, a large intramuscular dose of ketamine can calm a patient who is creating a risk to self and staff because of psychosis or delirium, or they're a medical problem. Intranasal ketamine isn't in my Pyxis yet, but it is FDA approved for the treatment of refractory depression, which seems really extreme until you think about the fact that our current best proven therapy for refractory depression is electrocuting people until they have seizures. So I was emboldened to use ketamine for all of these purposes by podcasters and bloggers and people with armies of Twitter followers who hailed the ketamine revolution as the dawning of a new age in ED anesthesia and analgesia. In true what is old is new again form, ketamine has become like the flagship medicine of this emergency medicine subculture. I mean, what other medicine will you find on patched up backpacks in your ED locker room? But what about ketamine's darker side? Is there anything we need to know about this medicine? Anything that the podcasters and the bloggers might have left out? What are the downsides of ketamine? What are the side effects that we need to know about before we go trying our first delayed sequence intubation? How can we hurt people with this medicine? Well, most of you will have heard of ketamine-induced laryngospasm. This is a rare but kind of scary complication of ketamine sedation. Often it can be overcome with a little bit of positive pressure ventilation or some painful pressure behind the angle of the mandible, or ultimately solved with a swift dose of paralytic and a breathing tube. Ketamine can also cause apnea. This is a little bit less of a fearsome specter than laryngospasm because most patients can be safely bagged until they start breathing again. I think that the problem of emergence phenomenon is much more concerning. So patients who are coming out of ketamine sedation can become delirious and agitated, ripping out IVs, screaming, and having family members or staff lying on them and trying to reassure them that they are not, in fact, outside their own body. Ketamine was thought for a long time to increase intracranial pressure. That's been disproven through in vivo studies of patients with ICP monitors who are receiving ketamine. But that doesn't mean that you won't have a fight with your neurosurgeon if you're trying to RSI a head bleed patient using ketamine as your sedative. But we've been told that ketamine is our go-to anesthetic for patients who are critically ill, hypotensive, trauma patients, or septic patients. And this makes sense because ketamine generally, in physiologically normal states, raises the blood pressure a little bit and raises the heart rate a little bit. And both of these are desirable effects in a patient with tenuous vital signs. This is accomplished through a catecholamine-mediated sympathetic surge. But what if I told you that rates of hypotension following ketamine administration range from 6 to 25%? And that patients who are catecholamine depleted because they're in shock are particularly vulnerable to this side effect. The very patients whose bodies are struggling to perfuse their organs and those who are most reticent to make hypotensive are most at risk. A positive shock index is associated with a 26% rate of hypotension following ketamine administration. And this is supposed to be our go-to anesthetic. And of course, the reason that we care about peri-intubation hypotension is because it portends the worst outcome of all: peri-intubation cardiac arrest. And this is a rare phenomenon, so it's difficult to study, but it has been reported, and it's happened to me, and I bet it's happened to people in this audience. Patients who undergo peri-intubation cardiac arrest, 50% will never achieve ROSC. So is ketamine's new popularity an answer in search of a question? I mean, what was wrong with good old-fashioned etomidate? In a head-to-head study in pre and post-implementation, there was no difference in patient-centered outcomes when intubating trauma patients. I meant what I said. I really do love ketamine, and I use it and use it often in our emergency department. I'd be willing to bet that I use it more than anybody else in the ED that I work in. But I think it's important to use it wisely and use it knowing the potential complications. Thanks.
Judges, go ahead.
Thank you very much. That was excellent and very thoughtful and balanced. I am the program director of a group of residents that loves ketamine, so I will definitely be bringing up some of the points that you made with them.